Hello and welcome to the Indian Health 101 presentation sponsored by the Administration for Native Americans within the Administration for Children and Families in partnership with the Center for Medicare and Medicaid Services, the U.S. Department of Health and Human Services. For information on future webinars, please visit healthy-tribes.org and join us on Facebook and Twitter. Healthy Tribes is intended to be a human service resource and discussion platform for all things related to American Indian and Alaska Native healthcare, so please join the discussion and get involved. Today's webinar will be recorded and accessible via healthy-tribes.org, where you will also be able to find the follow-up questions from the Q&A discussion. Today's presentation, Indian Health 101, is being presented by Captain Jim Lyon with CMS, and I will now turn the floor over to Captain Lyon.
Thank you, Alicia. As Alicia mentioned, I'm Jim Lyon. I'm Cherokee from Northeast Oklahoma. My grandmother was full-blood Cherokee. My maternal grandfather was Cherokee Creek and Shawnee, and my paternal grandparents were Cherokee and Anglo. This afternoon I have Miss Georgeline Sparks with me to help me respond to any questions we may get. Mrs. Sparks is Lakota from Rosebud, South Dakota, and has a wealth of experience working with IHS, ACF, and CMS. This is our third presentation as part of our partnership between CMS and the ACF. Today's presentation will include a little bit of information about Indian people, followed by an overview of the Indian health system, and we'll end with the role of CMS and other federal agencies within the Indian health system. The states play a major role in Indian health, but I will not address those very much, except that when I refer to CMS when talking about Medicaid and CHIP, I'm also referring to the states. On our slide deck today, we include some slides about the health insurance marketplace. However, I won't address those today, and we'll save that part of our presentation for our next webinar. We'll try to save a little bit of time at the end of our presentation for a few questions. Who is an Indian? American Indians and Alaska Natives are a very ethnically diverse population. There are 566 federally recognized tribes and half again as many state-recognized tribes with over 250 languages actively spoken. They range from the Everglades of Florida to the desert Southwest, from the woodlands and to both coasts, and as far north as Alaska. Each tribe has different customs, mores, and taboos. There are tribes who no longer recognize you as being Indians if you leave the reservation, tribes where a woman loses her tribal membership if she marries outside the tribe. Many tribes, in particular in the Southwest, have incorporated a lot of Catholicism as part of their culture. Some to the extent that if you're not married in the local Catholic Church, then you're not recognized as a full tribal member and cannot reside on the reservation. Some tribes are matriarchal. Some tribes don't let women vote. Some of the smaller tribes are losing their languages, just as tribes throughout the world, indigenous people, are losing their languages. Anthropologists generally indicate that you need to have a population of at least 5,000 fluent language speakers to maintain your language. And if you lose your language, you've basically lost your culture. Some people ask us if they should call us Native Americans, American Indians, Indigenous Americans, or by some other term. My recommendation is usually that it's best to call us by our tribe name. For instance, Navajo, Cherokee, or Shawnee. Recognition by your tribe as being Indian requires recognition by the tribe, some tribal membership documents, tribal membership of your parents, grandparents, or other ancestors. According to the U.S. Census, there are 5 million American Indians and Alaska Natives. Approximately 1.9 million of those American Indians and Alaska Natives are served by the Indian Health Service. CMS and other federal agencies, along with the states and territories, provide services to all 5 million American Indians and Alaska Natives. It is estimated that 60% of Indians live in urban areas. The primary reason for this is that back in the 1950s, the federal government tried to assimilate Indians into the mainstream population, and encouraged Indian people to move to large metropolitan areas like Los Angeles, New York City, Chicago, Detroit, Dallas, and Seattle, among others. This slide is a map that shows where the highest concentration of American Indians and Alaska Natives reside. The Tohono O'odham Reservation is the largest reservation. However, much of that reservation extends down into Mexico. The largest reservation that is entirely within the United States is the Navajo Reservation, which is approximately the size of West Virginia, or for those that are located in Maryland, this about 4 times the size of Maryland. Tribal governments are responsible for everything that occurs within the reservation boundaries. They have to deal with many of the same issues as state governments. Since we work in the Department of Health and Human Services, we sometimes forget that tribal governments have to deal with every department of the federal government and just not health issues. For instance, they deal with the Department of Transportation because they have roads on the reservations. They deal with housing, so they have to deal with housing and urban development. They deal with the Department of Education. There are reservation schools. They have everything from preschools, elementary schools, middle schools, high schools, and a few of the reservations have colleges and universities. In fact, earlier this year, Dr. Jill Biden delivered the 2013 commencement address at the Navajo Technical College in Crown Point, New Mexico. Tribes also deal with the Department of Justice because of their judicial systems. On every reservation, they have courts, jails, detention centers, law enforcement issues. One of the things about being on a reservation is that being a tribal or BIA police officer, it's considered to be one of the most dangerous types of law enforcement because they have enormous territories to cover and little or no backup. Tribal governments also deal with border issues because we have reservations that are on the borders of the United States. We have forests and wildlife, so we have to deal with the Department of Interior. Many tribes also have Department of Defense contracts and work closely with the military. A large percentage of tribal members are veterans. So we have veterans benefits on almost every reservation. Many reservations also have veteran cemeteries. The federal government entered into close to 400 treaties with Indian tribes between 1778 and 1871, many of which contain explicit promises to provide health care. Prior to 1778, many tribes also entered into treaties with England, Spain, and France. The U.S. Constitution establishes the basis of the government-to-government relationship in the Indian Health Commerce Clause, the Treaty Clause, and the Supremacy Clause. In Cherokee Nation v. Georgia, Chief Justice Marshall established the legal foundation for the federal trust responsibility by describing Indian tribes as domestic dependent nations whose relationship with the U.S. resembles that of a ward to his guardian. This slide shows a few of the documents and decisions that form the legal basis for the federal trust responsibility and the government-to-government relationship with Indian tribes. The Snyder Act provides a very broad authority for health care to Indians. In 1924, Indians were granted U.S. citizenship, in part in recognition for their service in World War I, where thousands of Indians served and died for their country. The primary CMS and state involvement in Indian health came in 1976 with the passage of the Indian Health Care Improvement Act. Title IV of this act amended the Social Security Act to provide authority for IHS hospitals and clinics to receive reimbursement for services rendered to Medicare and Medicaid beneficiaries. Per Section 1905B of the Social Security Act, states receive 100% federal matching payments for Medicaid services provided to Indian beneficiaries in IHS and tribal facilities. Sometimes that's called the FMAP. And so every now and then you hear about tribes saying, we're getting the 100% FMAP. That's kind of a misnomer because it's actually the states that get the 100% FMAP and not the tribes. And so anytime an Indian goes into an IHS or tribal hospital, the state gets 100% pass-through from CMS for any of those services rendered there. Because of the unique government-to-government relationship with tribes, many tribal members who have access to and receive services from the IHS will not enroll in CMS programs or private insurance if they have to pay premiums or cost-sharing charges. IHS is prohibited from billing or charging American Indians and Alaska Natives for services provided, and thus American Indians and Alaska Natives can receive care at no charge when they receive services in IHS, and this leaves them little incentive to enroll in third-party resources. And the main reason that Indians don't enroll in those other services because of our treaty rights and the promises that we were made by ceding over millions of acres of land. The federal agency responsible for Indian health care has changed over the years. In 1803, the responsibility was housed with the Office of Indian Affairs in the War Department, and in 1849 transferred to the Department of Interior to an office that was eventually renamed as the Bureau of Indian Affairs. Under the Transfer Act of 1954, responsibility was transferred to the Indian Health Service within the Public Health Service, which was in what is now called the Department of Health and Human Services. The federal trust responsibility for health care is a shared responsibility and not just the responsibility of the Indian Health Service. However, the Indian Health Service is the primary agency responsible for providing leadership in Indian health. Many of our sister agencies also work closely with tribes and Indian people. For example, SAMHSA spends millions of dollars on behavioral health contracts and grants with tribes. The Administration for Community Living works directly with tribal senior programs. HRSA works closely with urban Indian clinics and rural tribal hospitals and clinics and assists with health professional shortages, National Health Service Corps, and other contracts and grants. The Administration for Children and Families provides funding for Head Start, child care, TANF, LIHEAP, child support, family and youth services, and child welfare. The Centers for Disease Control provides epidemiology services, vaccines for children, the breast and cervical cancer program. You may recall the hantavirus epidemic back in the early 90s when we had the deer mice carrying the hantavirus in the Four Corners area of New Mexico and Arizona. The CDC worked very closely with the Indian Health Service at that time to identify the problem and help remedy that situation. CMS works with all IHS tribal and urban Indian health programs through reimbursement, accreditation, and beneficiary services. In 1955, Congress established IHS as a comprehensive primary care-oriented system of health facilities located on or near Indian reservations. IHS eligibility criteria is found in the regulations located at 42 CFR Part 136.12 and in the Indian Healthcare Improvement Act. IHS was established in the Indian Healthcare Improvement or in the Transfer Act in 1954, but it actually didn't get going until 1955. The Indian Health Service is not an entitlement program or an insurance program, and the services that it provides to eligible American Indians and Alaska Natives are limited by the amount of funding appropriated by Congress. Indian Health Service provides two types of services. One, direct health care services provided by IHS or tribally managed facilities, and two, contract health services that can be provided by IHS, contract health services that cannot be provided by IHS or tribally managed facilities and must be referred out to private health care providers. Contract health service funds are limited, and so sometimes you may hear about funding for health care running out before the end of the fiscal year and you need to get sick before July 1st or you may not have your health care covered. When you hear that, they're talking about contract health services. Since that funding is limited, it's usually only available for life-threatening illnesses and injuries. Sometimes because of some of the services that are sometimes delayed or deferred are services like cataract surgeries for seniors. Sometimes an individual may be offered to get one eye corrected while the other eye might not be corrected. Some patients may not be able to have necessary knee surgeries or shoulder surgeries. and so those services are deferred. And most of that is because of the shortage of CHS funding. The Indian Health Service is an agency within the Department of Health and Human Services and is responsible for providing direct services to federally recognized tribes. It's divided into 12 areas or regions. IHS areas do not have the same boundaries as the rest of HHS regions. For instance, the HHS Region 8 includes parts of Aberdeen, Albuquerque, Billings, Navajo, and Phoenix areas, where on the other hand, Navajo area includes parts of Regions 6, 8, and 9. So anytime we're dealing with the Indian Health Service or the tribes, a lot of times we have to deal with multiple regions. This slide provides a graphical representation of the ITU system and is straight off of the Indian Health Service website. When you look at this, the T part of the ITU system is on the far left-hand side, where they have 15 hospitals, 550 ambulatory facilities, and other facility types. Because the tribes have more opportunity to reprogram the services that they offer, the other tribal facility types include nursing homes, dialysis centers, school-based clinics, home health agencies, and regional treatment centers. IHS is pretty much restricted on their other facility types that they can offer, and so those include regional treatment centers. Even though IHS offers a lot of wraparound services like environmental health services, sanitation services, public health nursing, they can't have home health agencies, and until recently they could also not have nursing homes. They can have nursing homes now, however, their funding was not increased to add any nursing homes. Other urban facility types include behavioral health programs and referral centers. The urban facilities are usually fairly small and offer services to almost any Indian beneficiary that is located in their catchment area, including both tribal or state recognized tribes and tribes from Canada or Mexico. The extent of the health care services provided for direct services depends on local community needs and is dependent on the level of appropriations and medical priorities. This slide shows some of those facility types. Indian Health Service staffing includes almost 16,000 employees. 3,500 of those are nurses, almost 1,000 are physicians, 400 engineers, 600 pharmacists, 300 dentists, and also includes sanitarians, physician assistants, allied health professionals like nutritionists, health administrators, medical records administrators. Contract health services. These are services that are provided anytime a service isn't available in the Indian Health Service or tribal facility. Urban clinics don't have contract health services funding. And so if an urban individual requires services outside of their clinic, then they have to pay for those services themselves. As I mentioned earlier, the services under contract health services are pretty much limited to life and limb-threatening emergencies. If a beneficiary is wanting to receive contract health services or services outside of the Indian Health Service facility, they first have to apply for Medicaid or CHIP. If the beneficiary already has Medicare or private insurance, those insurances, along with Medicaid and CHIP, pay before contract health service pays, which is why Indian Health Service is the payer of last resort. They are the payer of last resort to try and conserve some of their resources. Under the Indian Self-Determination and Education Act, tribes were given the authority to take over the administration of many of their programs. And so if a program is currently administered by the Indian Health Service and a tribe opts to do so, they can take over the administration of that particular program. Approximately half of the Indian Health Service programs have been assumed by tribes under the Public Law 93-638. Under the Indian Healthcare Improvement Act, which also established the CMS relationship with tribal organizations. The government established the opportunity for the development of urban Indian clinics, and this is under Title V of the Indian Healthcare Improvement Act. I think I mentioned earlier that about 60% of the Indian population resides in urban areas. Only about 2% of the Indian Health Service budget is allocated to urban Indian health centers. Much of the budget is directed to reservation-based healthcare facilities. Part of that is because once you are integrated into an urban area, a lot of our population has opportunities for better insurance, private insurance coverage, and there are other HRSA-funded clinics, urban clinics, and services available to people once they move into urban areas. But there are still a lot of unmet needs for urban Indians. This slide depicts some of the health disparities among Indian people, and for more information about health disparities, you can visit the Indian Health Service website. They have a lot of information about health disparities in Indian people on their website. Medicare and Medicaid revenue is a very important and growing portion of the Indian health budgets, and it's important to bill for both Medicare and Medicaid services at the service unit level. When the Indian Health Service initially received the authority to bill Medicare and Medicaid back in 1976, the reimbursement rates were really small. So for an outpatient visit, the Indian Health Service might be reimbursed about $10 for an outpatient visit. And then in addition to that, the reimbursement didn't go back to the service unit or facility that generated the service. And so all of the reimbursements would go to IHS headquarters and then be distributed at some point in time on a need basis. Slowly over the years, the reimbursement rates have increased, and so now they're approximately $250 per outpatient visit, or a little over $250 per outpatient visit, and the reimbursements actually go back to the facility that generated the service. And so those funds now account for large portions of the service unit's revenues. And some service units, approximately even as much as 65% of their service unit's operating budget is from Medicare and Medicaid. As you can see here, of the population served by IHS, there are approximately 180,000 Medicare beneficiaries, almost 800,000 Medicaid beneficiaries, and almost 30,000 CHIP beneficiaries. These are just the Medicare and Medicaid beneficiaries that are served by Indian Health Service and don't account for the total enrollment of Indian beneficiaries throughout the country. Approximately 30% of the reimbursements for Indian people are in states where there is no IHS or tribal presence. In November of 2011, the CMS administrator, Dr. Don Berwick, signed the CMS Tribal Consultation policy, and we provide tribal consultation in various ways. Through face-to-face consultations with just CMS and the tribes. We also hold all tribes calls. We send out letters to tribal leaders. We also participate in the department's consultation when they have regional consultation sessions. Another way that we access information from tribes is by our Tribal Technical Advisory Group. And we created this Tribal Technical Advisory Group back in about 2003. And this group is comprised of representatives from each of the 12 IHS areas and representatives from the national organizations that are located here in Washington, D.C. Our Tribal Technical Advisory Group meets face-to-face 3 times a year, and we have monthly conference calls. And in addition to the main Tribal Technical Advisory Group, we also have various subcommittees that are made up of numerous technical advisors. Some of the barriers that we have to outreach include a language barrier. Many of our elders primarily will only speak their own language. And so one of the things that we've done recently is that we have some of our PSAs that are published in 5 different languages, not including English. For instance, we have language speakers and the written PSAs in Navajo, Lakota, Chippewa, Yupik, and in Inupiat. Some of the other barriers that we have are no different than any rural health community might experience when they're providing health services. And that is a geographic barrier. Most of our reservations are located in rural areas, and sometimes their beneficiary may be located down a dirt road, or they may not even have transportation. Some of our locations don't have cell phone services, don't have electricity, running water, and so there are significant geographic barriers. The primary barrier to enrolling in our CMS, Medicare, Medicaid programs are the federal trust responsibility, where many Indian beneficiaries, as I mentioned earlier, do not feel that they should have to apply for welfare-type programs like Medicaid or CHIP. And so because they feel that under the treaty rights, those should be services that are covered by the federal government. And so the remaining slides in this particular presentation are slides that will be used in our next webinar. And so at this time, I'm going to turn it back over to Alicia, and we can answer any questions that you might have.
Hi, everyone. As Jim just mentioned, that concludes the end of the presentation portion of today's Indian Health 101. We will now be addressing questions that have come in via the Q&A tool. Both the Q&A and the recorded webinar will also be available via healthy-tribes.org, and we will be sending that link out once again to everyone following the webinar. And our first question is, unsure how IHS provides health services for the Native American community in San Juan County, Stockton, California. I was told our county hospital has an exception and does not provide care without prior enrollment in the medical program. How do I find out the services available for our Native American community as to the closest Indian Health Service Center is in Sacramento County?
Good afternoon. This is Georgie Spark. And IHS has a tool on their page at ihs.gov that you can click on and find the closest IHS facility, and that could be a tribally operated facility, an urban clinic, or a direct service provider. So other than, I won't be able to tell you exactly what is closest to you, but for that question, or any questions about where is the closest IHS facility, I would ask you to go to ihs.gov and put in your location and ask for the closest facility to you.
Our next question is, what was the topic of the next webinar going to be?
The next webinar will be the health insurance marketplace, and that will be in early January.
Okay, and then it looks like our final question is from Nadia Najim, and she asks, do you have products that explain the benefits of enrolling to not just the individual, but that it increases the resources for IHS to provide back to the service providers?
We have several products that CMS has developed, and if you should go to healthcare.gov/tribal, there are questions and answers there, as well as there will be links to actual products. You'll be able to actually click on the link and be able to download specific projects. So we have actual printed materials that you can print out. We have several DVD PSAs that explain different CMS programs and the benefits of enrolling in Medicare, Medicaid, and the Children's Health Insurance Program. We are developing outreach materials, especially PSAs and DVDs that explain the health insurance marketplace. that particular product's not yet available. It is completed, but it's going through clearance. As Jim explained, there are PSAs out there, and if any of you have access to Konak Broadcasting, Native News Online, the PSAs are run in 5 specific languages, and each month there's a different message. So the month of December, the campaign will be called Get in the Game. These PSAs currently are being aired on KEYA, which is in Belcourt, North Dakota, KILI, Keeley Radio, which is out of Porcupine, South Dakota, Konak Broadcasting, which airs across Indian country and feeds into many of the Indian radio stations, as well as KTNN, which is the Navajo radio station. So we do broadcast it out. We are putting printed PSAs in several newspapers across the country, again with the same campaign message. So in December, you should be hearing the PSAs in our native languages in those radio stations, as well as in newspapers. But the newspaper will be in English. I don't know how many of you seen this past summer. We had billboards across the country, again with the same campaign, Peace of Mind, Get in the Game. I know that there were billboards right outside of Albuquerque in California. There were bus billboards in Seattle. I know there's one billboard that's still up in Rapid City, South Dakota. So it's those kind of PSAs that we try to get out into our communities. Does the website include information on how to order access to information I just mentioned? If you go to and Google CMS Tribal Affairs Group, it will take you directly to Jim and I's office website, and there's a product ordering page there. But again, we will give this information to Alicia, so she will post it up with the information and include it with this webinar. Are there social media PSAs for Facebook?
Yes, if you go to healthy-tribes.org at this time, we've already started some social media through Facebook and Twitter, so please join us as soon as you can, and we will be sharing other information and campaign products through those venues.
And certainly we'll be able to share with Alicia the audio files for those social media. We don't necessarily have a YouTube that goes along with them, but certainly you'll be able to hear the various audio files.
Okay, the next question is, how or what can we as Native people do in having our health care continue as far as funding for IHS services? And one of the things that we can do as Indian people is to encourage those people that are eligible for Medicaid or CHIP to actually enroll in Medicaid and CHIP, because anytime we have additional resources coming in, it increases the number of services that are available for IHS and tribal programs, and it also it helps both the IHS and tribal program, but it also helps the state as well because of the 100% pass-through for those services going to IHS and the tribes. And so whenever we have beneficiaries that are on Medicaid that go to private facilities, that's just money walking out the door. So if we can work with our tribes as IHS and tribal health programs, if we work with our tribal beneficiaries and provide the services that they need, then we can increase the number of services that are provided in those facilities. And the next question is, what is IHS doing in working with Congress as far as not being part of the sequestration? That's not a question that we can answer here from our particular agencies, and so that's something that we would have to pass on to the Indian Health Service.
If you're not a member of a fairly recognized tribe, do you have to sign up for what people refer to as Obamacare? Yes, there are specific provisions within the Affordable Care Act, the Health Insurance Marketplace, that are specific to fairly recognized tribes, but there are some additional language that if you're eligible to be seen at an IHS facility, that you can request a hardship exemption, and that information will be forthcoming. And again, I'm going to ask you to please join us in next month's webinar where we'll get into more specifics of the health insurance marketplace. And why do these health disparities still exist? Part of it, again, is because of funding. People don't realize that IHS has really been only around since 1956. So our history is not that long as far as an agency. And it is discretionary. It's not entitlement monies. So again, each year the monies that is appropriated to IHS is discretionary. It's not entitlement or mandatory. And again, the health disparities that we see in our tribal communities, is just exacerbated because we don't have enough money. And that's part of our reason for being here in the Tribal Affairs Group and within CMS, is to get the message out to those tribal members who are eligible for Children's Health Insurance Program or the Medicaid program or the Medicare program, is to encourage them to sign up so that they do have additional resources to them as individuals, but also the reimbursement that goes back into those tribal facilities helps the greater good of the community.
Okay, it looks like that concludes our questions. So if there are no more, that will conclude today's presentation. Thank you all once again for joining us, and please don't forget to visit healthy-tribes.org for information on all future webinars, as well as the Q&A from today's webinar and the recorded presentation. As I mentioned before, we will also be sending everyone a link to this information to everyone who joined us today. And thank you very much, and have a wonderful evening.